Now we'll start to do the job. How can I do plan A? Tracheal intubation. It's not just to give the patient 2 or 3 cc of propofol to sedate him and just have a look and put the tube. Wrong. It's not like this. We need, firstly, to put the patient in optimum position. This is the very important, the most important message today. Position, then position, then position. 90% of the problem because of wrong positioning of the patient's head. We need to keep the patient's head in the sniffing position to make the air meatus in the same horizontal plane with suprasternal notch. So it's called the sniffing position, simply to flex the neck and extend the head. Let's see first a video which confirm and explain the importance of optimum positioning, and then go back again to that slide.
First thing I would like to talk about is positioning. The important thing about positioning is you have a patient here, right? And you notice what we like to do is we want to align the auditory meatus, that's the ear hole, with the sternal notch. And that will facilitate optimal view, right, when you're trying to intubate. So if this was a bouquet of flowers, right, I'll have my partner here, Miguel, can you sniff the bouquet? Sniff the roses for me. Okay. Go ahead, come closer, right? Good. So do it again. So he has auditory meatus, the ear hole is aligned to the sternal notch, and that's what you want to accomplish, thank you, with this patient. So ideally what I want to do is I want to have some sort of a padding where I put this under the head, right? And to show you the difference, I'm going to use a kaleidoscope to show you the view. Here, right, when I come in, right, I'm looking at the screen, right? The moment I see the top of the epiglottis, I'm going to insert into the vallecula, and this is the view I see. This is the optimal view with proper positioning. Now watch what happens when I take away the padding. You notice how it collapses, right? So here again, I'm going to use my hand. I'm going to again align the auditory meatus with the sternal notch, optimal view of the vocal cords, and now I'm going to let go. Now you have loss of your vocal cords. So whenever you are positioning the patient, always align the ear hole with the sternal notch, right?
So have you noticed the difference in the view when he removed the pillow from underneath the patient's head? So please don't remove the pillow underneath the patient's head. Keep sniffing position. This is very important to get a nice airway view and successful intubation. The idea behind that, here without putting something below the head, so you can find the oral axis and pharyngeal axis and laryngeal axis away from each other, so it's difficult to see anything. But when we put something below the patient's head and keep sniffing position with flexion of the neck and extension of the head, the three axes almost come close to each other at least. So it's easier now to see the airway view and proceed for successful intubation trial. This is extremely important, the position. Always remember, sniffing position. Put something below the patient's head and don't remove the pillow. Then we need to spend 3 to 5 minutes to pre-oxygenate the patient. This is very, very important. Open 100% of oxygen via face mask for 5 minutes at least. This is going to give you some time. You buy time for yourself and your patient. We replace the whole nitrogen inside the lung with oxygen. So you prolong the time to hypoxia. Usually, if the patient on the room air, it gives you 1 to 2 minutes to do the intubation. But with effective pre-oxygenation, you have 8 minutes. Can you imagine? 8 minutes time to hypoxia. So this makes the intubation trial very safe for you and for the patient. Pre-oxygenation. Give it some time. 3 to 5 minutes at least, 100% of oxygen. and then we give induction of anesthesia. Propofol or ketamine or thiopental, all are nice options, but here I need to confirm we use the propofol in anesthesia dose, not sedation dose. It's not 2 cc or 3 cc, no. We give anesthesia dose. So it's 1.5 to 2.5 mg per kg, so it should be 10 ml at least. We need to put the patient under anesthesia, not sedation. If the patient is hemodynamically unstable, septic shock, something like that, it's preferable to give cardiovascular stable anesthetic medication like ketamine and try to avoid propofol. Once you induce the anesthesia, the patient will lose his consciousness and also will lose his control over his airway. That's why we'll start to do cricoid pressure. So try to localize the cricoid cartilage, press it to occlude the upper part of esophagus and decrease or minimize the risk of aspiration. Cricoid pressure is very important, and we are concerned about that if the patient's stomach is full. And this is the case in most of ICU patients. Usually they are on NG feed, and for some reason we need to intubate them now. So the stomach is full. There is serious risk and considerable risk for aspiration and the contamination of the airway. That's why it's quite important to do cricoid pressure. This is not usually the case in standard induction when I deal with the elective prepared patient who is fasting for the last 12 hours before surgery. Usually this is not important to be done. And then we give the other medication, the muscle relaxant. We need to paralyze the patient. This is going to make it very, very easy intubation trial for you. So usually we give succinylcholine or better in ICU patients to give ricuronium, 0.6 to 1.2 mg per kg. Especially they have comparable onset and the duration of actions, and the ricuronium has its own antagonist, which is sugamidex, 16 mg per kg, if something happened and you need to reverse its action. So it's a very nice option as a muscle relaxant in ICU patients. Especially succinylcholine can cause serious hyperkalemia, and the most ICU patients might have potassium problems or acute kidney injury. So we need to be cautious if you decide to use succinylcholine over the ricuronium. I think ricuronium is going to be more safer in ICU patients than succinylcholine for the potassium issue mainly. After giving the medications, anesthesia, and the muscle relaxant, the patient now is ready for the intubation trial via direct or video laryngoscope. Once you see the view and put the tube, you need to confirm the correct tube placement by end-tidal CO2 capnography. This is the gold standard. Then you can release the cricoid pressure after confirmation of the tube position. That's it. This is plan A by book, by guidelines. Should be done like this. Optimum positioning, preoxygenation for 3 to 5 minutes, induction of anesthesia, and the same time start cricoid pressure, muscle relaxant. After medications, proceed directly to intubation, then confirm the position of the tube. What we have done now is called rapid sequence induction, and we need to do it this way when the patient has full stomach and unprepared. Here is the difference now between the standard and the normal induction, the elective patient with empty stomach, the prepared one, and the rapid sequence induction when you have emergency patient or ICU patient with full stomach and not prepared at all. In both cases, we do preoxygenation. In both cases, we do the induction of anesthesia. Cricoid pressure is going to be important here, but not done here, not necessary to be done here. Muscle relaxants in both of them. And there is some time to give face mask ventilation and oxygenate the patient again between giving the medications and the intubation trial. This one is done for the normal induction, but is not done in rapid sequence induction. That's why it's called rapid sequence, because we don't do this. We omit this step. Especially the stomach is full, and I'm afraid that I may introduce some air inside the stomach, insufflate the stomach, and increase the probability of vomiting and aspiration. That's why I omit that step and proceed directly from drugs to the intubation. That's why it's called rapid sequence induction. To intubate the patient after giving the medications directly and without delay. Nowadays, there is what's called modified rapid sequence induction with different medications for anesthesia, different medications for muscle relaxation, and the different ways to pre-oxygenate the patient. And here they mention that you can give what's called gentle face mask ventilation, especially in ICU patient with poor oxygen reserve and lung pathology before intubating him. So this is the difference between the rapid sequence induction and the normal, usual, standard induction in empty stomach patient, the prepared patient. So to summarize, Plan A, optimal position, pre-oxygenation, medications, intubation. You can facilitate the intubation trial by some external laryngeal manipulation using a bougie, stylate to remove the cricoid if necessary. If you succeed, confirm the position. On the right side, this one is specific for patients. The only difference that we have another options to pre-oxygenate them, including CPAP and NIV, for the same reason we mentioned before. Because the ICU patient is hypoxic and he has bilateral basal atelectasis and a very low functional residual capacity, as you know. So sometimes we need to pre-oxygenate them with NIV or CPAP, and even to maintain the nasal oxygen all over the trial to keep what's called apneic oxygenation, to maintain the oxygenation until I finish the intubation process. So there is no big difference between the anesthesia guideline and ICU guideline, as you see. For the intubation trial itself, we can do it by direct laryngoscope or video laryngoscope, which is much better than the direct one. As you know, direct laryngoscope, by the way, was invented in 1950 and still the gold standard in our clinical practice till today. And I don't know why. I can't find a reason for this. For 70 years, we still use the same method. 70 years with no improvement at all. I think if you can look at this nice, funny video, you can find out how they changed the tires, for example, in the formula in 1950 and compared to what's happening now. That was in 1950.
But Holland comes in for a pit stop. Time to refuel and change tires. Comes in for a pit stop. Time to refuel and change tires. Lou Moore himself changes the tires. Only 4 crew members, including the driver, are allowed.
Previously, they took too long to change the tires. But that was normal in 1950. Look at the difference now. So, so this should be the difference between 1950 and 2020. But intubation is not like this. Intubation in 1950, by direct laryngoscopy. Intubation in 2020, it is still by direct laryngoscopy, which is not accepted for me. We have very nice and beautiful other options. We have video laryngoscopy now. We should consider this as a standard method of intubation nowadays, especially after the presentation of COVID-19. And this one as well. So you can just introduce it, get a nice airway view, and also it gives you a good distance between you and the patient's mouth. And again, I think it's very important nowadays after presentation of COVID-19 to give us distance and protection for our staff by using video laryngoscopy rather than direct laryngoscopy, to be very close to the patient's mouth as usual. And finally, let's mention some important tips about Plan A. Before introducing the blade, open the mouth maximally by cross-finger technique, or scissor finger technique. So the thumb for the lower jaw and the index or middle finger for the upper jaw, like this, or like this. This gives you a plenty of room to move with your blade and to make sure that we are not compressing on the teeth and upper lip. And as you know, to introduce the blade from the right side and take the tongue away, not from the middle, not from the left side, because the tongue will fall in front of you and it will give you no room to introduce the tube. So take the tongue away and push in this direction. Always push the lower jaw, the mandible, in this direction, not that direction, and break the patient's tooth or traumatize the upper lip. And this will be the final view. The tongue is completely away. Very nice view. I have a plenty of room to put the tube. That's it.